Hello, and many thanks to the organising committee for inviting me to give this important keynote lecture to the Paul Strickland Scanner Centre Oncological Imaging course. I'm Jeanette Dickson. I'm the current president of the College of Radiologists, but for those of you who are on Twitter or on the website, you will know that currently the nominations are open for my successor. So if you are a radiologist, feel free to have a look. But I'm here today to talk about the challenges and opportunities for service delivery in oncology and radiology. So yes, as I said, I'm a clinical oncologist, but I do spend a lot of time with radiologists and therefore know quite a bit about radiology service delivery, and I've learned an awful lot more over the past few years. However, I do work closely with all members of the wider multi-professional team, and I think anytime we talk about service delivery, we have to talk about that multi-professional team. So what do I think are the challenges in service delivery? Well, there's workforce, and workforce. In fact, if I ever come to the point where I don't say workforce, either something amazing has happened or I've kind of completely lost the plot. But there's also equipment and there's the IT connectivity issues. So the RCR undertakes a workforce census in both faculties each year. It is done as a snapshot survey of the situation on one day, and we now have 10-year longitudinal data from both faculties. The census documents are much the same for both faculties. At core, they look at number of DCCs, number of SPAs, amount of research undertaking, less than full-time working, age at retirement, but there are some differences. In radiology, they focus very much on the amount spent on outsourcing and the funding for that, and also have focus areas on certain aspects of radiological practice. At the moment, the focus is on interventional radiology. For clinical oncology, it's much more a focus on extended hours, how many days of the week and how many hours are you open routinely to deliver chemotherapy and radiotherapy. The documents are both open at the present time, or the new census is open at the present time. So if you are a clinical director, or if you know a clinical director, could you nudge them to fill in the census for us, please? The main value of the census data is that it has 100% return rate from all centres, and that's one of the things that we can use when we talk to our political masters about gaining more funding. So please nudge your clinical director. For radiology, the summary is very much as you would expect. Outsourcing funding is increasing, demand is increasing, there's a huge shortfall in the gap, and there is inadequate capacity, and worryingly that there are a significant number of places which cannot deliver safe care for interventional patients. The impact of the pandemic is not yet established, but a significant number of colleagues are indicating that they will leave. The statistics in frank terms are that there are 433 funded vacancies as of this moment up and down the country, which is 10% of the total headcount. 50% of these have been vacant for more than a year, which is not a good outcome. There is a demand, as we say, demand is increasing, and the demand that we put on outsourcing plus those vacancies together come up to 1,939 vacancies, which is 33% of the total. This is nationally accepted. Professor Sir Michael Richards, in his Diagnostics Recovery and Renewal report, used a very different methodology to work out what the shortfall gap was, and he came up with 2,000 new radiologists. By 2025, this shortfall will have reached 44%. So that's an eye-watering size of a shortfall. To come to work when you know that there's only half of you there who are needed to do the job is a really mind-boggling statistic. In oncology, things aren't much better. We have significant impact on patient care. We've had an increase in complaints. We've had suboptimal care. We've got patients who are unable to be seen if their cancer is advancing while people are on holiday. And I think what we know is that we do not have enough people in training to fill those gaps. The statistics are slightly different in oncology. We have 8% funded vacancies with 87 posts out to advert at the present time. However, 55% of those have been vacant for more than a year. The demand shortfall in oncology is much more difficult to ascertain because we don't have outsourcing. However, if you take everybody who works above 10 PAs and make the assumption they would only want to work 10 PAs and add that to the vacancies, then we have 189 people short in the workforce, which is 18%. Now, you may say, well, 1 or 2 people doing a bit of extra work is fine, but if you think that 1/3 of all consultants, that's men and women, work less than full time, that 100 vacancies, which represent overtime, has been spread out amongst 2/3 of the workforce, and actually most of them say that they don't want to be working as hard. They want to improve their work-life balance. By 2025, this shortfall will reach 28%. So again, it's a huge shortfall, and unlike in radiology, the outsourcing is not available to soften that blow. In terms of equipment for radiology, we know that the UK, in terms of CT scanners, has half of those roughly in France and 1/4 of those in Germany. MRI is worse, but more worryingly, the 100 CTs, there are more than 100 CTs currently which are greater than 10 years old, which means they're obsolete, they take longer to service, they give a higher radiation dose during scans, which is not good. They are out of action more often, and they cannot run the newer algorithms which would help increase efficiency. Pre-pandemic in the UK, well, in England actually, there were 30 acute sites, so 30 A&Es who had 1 CT scanner to do all of the emergency, all of the inpatient, and all of the elective outpatient work. That has been reversed by the recent equipment monies delivered by the government, but it still shows that the equipment base is way below where it should be. In oncology, benchmarking is much more tricky. The best figures I can find are that the UK has 6.1 per million Linacs per million population, and France and Germany have 8. So we are behind, but the gap is not nearly so far to cross. The age of the equipment is more concerning though, because again, it's that ability to upgrade your equipment to run the newest programs, to run the new technologies for treatment, and it's also the huge amount of professional time and effort wasted across the multi-professional team writing business cases for new kit, rewriting them, writing them again. It takes on average for 5 years for a new Linac to be ordered, so that's 5 years of business case writing that we could save if we had, for example, a funded rolling equipment replacement service as they do in Scotland. IT infrastructure and connectivity is the bane of everybody's life. As we know that there is a lack of informal sharing between rival organisations across the board. It's not just in oncology or radiology, it's every aspect of healthcare. There's a lack of ability to share records between primary and secondary care, leading to patient and staff frustrations. There's a lack of image sharing, which leads to repeat imaging and excess radiation doses to patients, which is not good. But it also means that a capacity that's already struggling is forced to redo tests that are available somewhere else. I think the lack of the comprehensive patient safety record that follows the patient through all of their journey in primary and secondary care and is able to be added to by all people equally leads to significant patient safety concerns going forward, especially as medicine becomes more complex and people are moved between providers, but also as a result of the elective backlog between the NHS and the independent sector. So the first thing we need to do, I think, is to retain the workforce. We don't have enough, but we need to keep everybody who's there, and we need to keep them working at the highest level we can. Now that poses a slight contradiction because people who are only doing service commitment are much less happy in their job and much less likely to stay. And we also know that people who work full-time are likely to retire 3 years earlier than those who work less than full-time. So there's something about knowing that we need make people work as hard as they can, but there's also something about saying that if we want to retain them at all in the workforce, we need to be more flexible about how job plans are devised, about the ability to do on-call. We need to think a lot more about innovative working patterns, including remote working, and we do need to think about the pensions crisis. We in the RCR are currently updating job planning guidance in both faculties to include the issues raised by our staff in our wellbeing report to allow people to job plan to improve their work-life balance. The report you see there is the one that we produced about health and well-being in our specialties. It signposts to a lot of nationally available resources which are extremely well thought of to help people in that sphere. But actually, more importantly, it reminds you that patient safety depends on the well-being of staff. So to care for our staff is to care for our patients. And if we don't care for our staff, it is the patients who will suffer. And I think that message really needs to be brought home at all levels in the NHS. Overseas recruitment, we had, prior to the pandemic, a Global Radiology Fellows programme, which we ran in partnership with Health Education England Global and Apollo Radiology International. Unfortunately, this was limited to England alone. Following the pandemic, we aim to reinvigorate the scheme as we can travel again, but also extend it to clinical oncology. I'm aware there are other schemes for other professionals within the multi-professional workforce, but we need to really think about how we promote people to come to Britain for a short period of time to gain more skills, more experience, to experience a different healthcare setting. But we need to be careful that we don't strip our colleagues abroad of much needed resource from their country. We need to also train other doctors. Both specialties have staff and associate specialist grade doctors within them, but relatively small volume compared to many other specialties. I think that does reflect the significant emphasis on radiotherapy and radiation physics in the higher specialty training curricula of both specialties. But we can grow that workforce. One of the places we've grown it very, very well is within the breast clinicians. The picture you see here was last year when we were nominated in the Women's Health Team of the Year category for the breast clinicians credential. This was a structured training programme developed between the college, the Association of Breast Clinicians, the National Breast Imaging Academy, and again Health Education England. The first people who have been trained in this cohort will graduate this year, and the second cohort will start this year as well. So there are ways that we can boost the medical workforce. What about the non-medical workforce, skill mix and role extension? I mean, oncology is an early adopter. It's a well-established practice in oncology centres, and there are now a proliferation of multiple roles which have little commonality or standardisation and little understanding of what is expected of the person in that role. So we're working with the statutory education bodies of the four nations and our colleagues in the nursing fraternity and the radiographer fraternity to come up with a very standardised role model which can only help improve recruitment and retention and career pathways for our colleagues. We're also working with NHS England and Improvement, looking at sharing best practice in skill mix, building on the previous work that we published as part of the CRUK document Full Team Ahead. We're also on the radiology side working with the College of Radiographers on training standards for reporting in musculoskeletal radiology. This has taken a while to come to fruition, but we are aiming to publish within the next few months and looking to start moving on to other topics. And I think this is a really good paradigm of how we can support each other and to ensure that patient safety is foremost in everyone's minds when we talk about skill mix. Artificial intelligence is another thing that is often brought up to me by those of my political masters. The phrase that the next radiologist will be a computer was one that has thankfully fallen out of fashion. Where is artificial intelligence as we speak? At the moment, at best, it's an assist. It can do some routine, simple and frankly boring tasks. It can measure nodule volumes quite accurately, and it's beginning to be very useful in outlining organs at risk for clinical oncology, but it's not perfect. It's quite good for questions that have a binary answer. Is there blood in the brain, for example? Should I have chemotherapy? It's not very good for that integrated, complex, multiply comorbid patient who the trial doesn't tell you what to do with, or the imaging doesn't tell you what is the most important feature. And I think that is where the population is heading, into old age and multiple comorbidities, and that's where the specialties, both specialties, will find their expertise is of most use. So do I think artificial intelligence will be a replacement? I think for some tasks it will replace doctors, but not for a while, not for 5 years yet at least. Do I think it will replace that person-person interaction, be it doctor-doctor or doctor-patient, those complex medical discussions that we have all the time? I don't think it will. What other assists are there? Well, in radiology, we have the demand management tool of iRefer, which will help reduce redundant imaging, but only with proper IT investment. NHS, this product is available in all three of the devolved nations, Wales, Scotland and Northern Ireland, and this year we have heard that NHS England has bought the product to roll out to all GP practices and secondary care settings. But even if we demand manage appropriately every test, the capacity in imaging needs to increase. We still need to image more, so this will help, but it won't solve the problem. And what about networks? We have the imaging networks which are being set up, and we also have the operational delivery networks for radiotherapy, which came into being last year. They will release some efficiencies, I think, but only if the IT infrastructure is invested in, which will facilitate sharing of protocols across regions, be that for cancer treatment or the acquisition of images, for example, for metastatic spinal cord compression. They may allow areas of service support in times of unexpected crisis, such as sick leave, in niche areas such as paediatric radiology or head and neck cancer, but they will not bridge the huge shortfall in workforce of themselves. So where are the opportunities that I've talked about? I think the major opportunity we have to talk about is an enhanced IT infrastructure. Upgrading the IT so that there is no longer the blue circle of death on the computer screen will improve patient safety. Improving connectivity will release efficiencies and will allow the NHS to function as a proper 21st century organisation. And I think we need to increase our advocacy for IT solutions. I think enhanced connectivity will allow us to stop thinking about the patient in front of me, the patient in my hospital, and will start to allow us to think about the population health, the patients as a general concept. And I think that widened view of the patient need for the health service rather than my organisation right or wrong is a long overdue one to change, and can only reap the benefit for our patients. There are new pathways and new ways of working, community diagnostic centres for radiology, remote consultations for oncology, but these are not the only ones. We need to embrace these changes and work with them. Undoubtedly, they are not perfect, and undoubtedly they are not universal panaceas for everybody, but they will provide different ways of working, and we need to work out what's the best way to treat every patient, what's the best way to manage the pathway for this particular patient. What other opportunities are there? Well, I think we have messaged effectively, certainly from the college point of view, but also amongst radiographer and nursing colleagues, and to some extent the technological professions, for more staff. But we do need to shift the focus not just for more to retention. And I think well-being will be the key for the most successful employers over the next few years. If there are as many vacancies as there are, and we know there are, and if there are as many differences in the way that employers interpret national guidance, then actually people will shop around. The loyalty only to my trust for 20 years and no movement is not something that is topmost in the minds of our more junior consultant colleagues, but also as we get towards the end of our careers, the ability to move more, to shop around, to try new things, to try new places is going to be very high. And I think employers need to up their game. We do need to continue the lobby to expand training posts across all the professions, but we need to be willing to train if those numbers are delivered. And we need to acknowledge that expansion will mean that we have to change how we train. We need to innovate in training. We need to look at all the different modalities we can use to ensure that our colleagues are fully trained for the changing environment that will be coming. And I think we also need to have a think. I think it's really difficult when we're all so busy to go, what would I like to change about my environment? We all grumble about it. Oh, I'd like to. Oh, no. But actually, I think we need to take a bit of time to step back and go, what would I like to change if I could? Because actually, I think at the moment we have the chance to change things, or we have the chance to highlight the need to change those to our political masters, because they recognise that we actually do need to think about the workforce retention and not just numbers, but a happy and productive workforce. I hope that you found the talk interesting and provocative and challenging, and I'm now willing to take questions. Thank you very much.